Hello, everyone, and welcome to the Society for Immunotherapy of Cancer's Clinical Practice Guideline webinar, Immune Checkpoint Inhibitor-Related Adverse Events. Thank you for joining us today. During today's webinar, the faculty will review CITSE's recently published Clinical Practice Guideline on Immune Checkpoint Inhibitor-Related Adverse Events, which was published in the Journal for Immunotherapy of Cancer on June 25th, 2021. After an overview of the guideline, there will be a question and answer session with the faculty. Continuing education credits are available for physicians, nurses, and pharmacists who attend today's webinar. More information on how to claim credit will be provided at the end of the webinar. You're encouraged to ask questions during this webinar. As I had mentioned, there will be a dedicated Q&A session, which is a great opportunity to engage with the webinar faculty who are all members of the CITSE Immune Checkpoint Inhibitor-Related Adverse Events Guideline Expert Panel and authors on the publication. You may submit questions at any time, and they will be addressed during the Q&A session at the end of the webinar. Please use the Q&A icon to submit questions. The chat function should only be used for technology or connection-based questions. Faculty will not answer any questions prompted in the chat. I would now like to introduce the moderators for today's webinar. Dr. Julie Bramer is the Director of the Thoracic Oncology Program and Professor of Oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. Dr. Bramer is an international leader in lung cancer clinical trials research with particular expertise in drug development for thoracic malignancies and immunotherapy. She has led early phase immunotherapy trials of anti-PD-1 antibodies, international phase 3 studies of immunotherapies in lung cancer, and investigator-initiated trials evaluating combination immunotherapies. Joining Dr. Bramer in this role is Dr. Ernsthoff. Dr. Mark Ernsthoff is Chief of the Immuno-Oncology Branch of the National Cancer Institute's Division of Cancer Treatment and Diagnosis. A renowned oncologist, much of Dr. Ernsthoff's career was spent at Dartmouth College's Geisel School of Medicine, where he was Section Chief of Hematology Oncology and Deputy Director of the Norris Cancer Center. He has published over 250 original research manuscripts in the areas of renal cell cancer, melanoma and immune therapy strategies, including cytokine therapies, dendritic cell vaccines, immune checkpoint inhibition, targeted therapies, and ex vivo expanded effector cells for adaptive transfer. Together, Drs. Bramer and Ernsthoff serve as co-chairs of the CITSE Immune Checkpoint Inhibitor-Related Adverse Events Expert Panel. Thank you both for joining us today.
Unmute there. Thank you, Miles. And I appreciate it on behalf of Dr. Bramer and myself, your kind introduction. It is a pleasure now to introduce an internationally renowned faculty and friends and colleagues from across the world that will give the talks today. First will be Dr. Gregory Masters. Dr. Masters is a medical oncologist at the Helen F. Graham Cancer Center and Research Institute in Delaware and an associate professor at Thomas Jefferson University. Dr. Masters is currently principal investigator for the Delaware Christiana NCI Community Oncology Research Program, or NCORP, and serves on the Alliance Board of Directors. His research interests and publications have focused on multimodality therapy of lung cancer and investigations of new drugs in lung cancer. Dr. Paolo Ascierto will be joining us from Naples, Italy. He's the director of the Unit of Melanoma at the Cancer Immunotherapy and Developmental Therapeutics at the National Tumor Institute in Naples, Italy. Dr. Ascierto has presided as principal investigator on over 800 clinical trials and is authored to more than 300 publications in peer-reviewed journals. His major research interests have included research in the genetics and proteomics of melanoma, assessment of new molecular markers for tumor progression, biochemical and immunological monitoring, immunotherapy, vaccination strategies in solid tumors, and combination strategies with IO. Dr. Ascierto, I should also say, has been a primary mover in the treatment of COVID-19 in cancer patients. We appreciate all of his efforts on behalf of our patients. Dr. Igor Puzanov will be the final speaker. He holds multiple titles in the Department of Medicine at Roswell Park Comprehensive Cancer Center, including the director of the Center for Early Phase Clinical Trials. Dr. Pusanov's major interests are in the development of novel therapies in cancer from early preclinical phase through phase 1, 2, and emphasis on combination of immune and targeted novel drug design, including histology agnostic trials developing targeted therapies. He has focused on immunotherapy since the early 1990s and has recently conducted phase 1 studies with PLX4032, vemurafenib, the breakthrough BRAF inhibitor in patients with melanoma, as well as pembrolizumab, TVAC, and other immunotherapies and combinations. And he was also very involved with the treatment of COVID-19 patients in Buffalo, New York. Next slide. The learning objectives today will be one, to select appropriate diagnostic and biomarker testing for patients being considered for immunotherapy based on this expert panel of recommendations in the SITC clinical practice guidelines, which you can see recently published. The implementation of immunotherapy treatments effective and appropriately according to the recommendations in the CPG. You should be able to appraise patterns of response to immunotherapy in order to appropriate monitor and manage patients during treatment, identify signs and symptoms of common immunotherapy-related toxicities, and implement appropriate management strategies based on expert panel recommendations. You should finally be able to describe the considerations available tools to assess and support patient quality of life during immunotherapy treatments. Next slide. This is the reference, the Society of Immunotherapy Clinical Practice Guidelines on Immune Checkpoints, recently published in the Journal of Immunotherapy for Cancer. Next slide. The guidelines were developed with a panel of 23 experts in the field, and they use the Institute of Medicine Standards for developing trustworthy clinical practice guidelines. The recommendations are based upon published literature evidence, as well as clinical evidence where appropriate. And consensus was defined at 75% approval among the voting members. Next slide. The webinar outline will provide you an introduction to the guidelines, which I've just given you, general immune-related management of common immune-related adverse events and more serious adverse events and life-threatening toxicities. Next slide. So in general, we can move, next slide. So am I going to continue this, or Dr. Masters, were you going to take it from here?
I think I'll take it.
Okay, Dr. Masters, you're on. And thank you very much for joining us. And I look forward to the talks.
Okay, thanks very much, Dr. Ernstoff and Dr. Bramer for inviting me. It's really been a pleasure participating in the development of this important guideline, and I'm excited to further discuss the general management of immune-related adverse events, or IRAEs. I'm going to talk about the type of adverse events that we see as we approach the management of these adverse events. I think it's important to remember that we're dealing with complicated cancer patients who have a lot going on, including their cancer, but also that cancer may be widely metastatic, and they may be receiving varying therapies in addition to immune checkpoint inhibitors. So they may be receiving chemotherapy, targeted therapies, surgery, radiation, and they may have comorbidities that are already pre-existing. And so in order to manage these, we have to take all of that into account and try and decide, what is the problem going on and how are we going to manage it? And we can't forget the psychological stresses of cancer and cancer treatment that also play a role. So adverse events in these patients should be triaged into those that are unrelated to treatments or immune-mediated toxicity, and those that are treatment-related. Again, among those that are treatment-related, it could be related to a different part of their therapy. And so we're trying to differentiate which of these are actually related to the immune checkpoint inhibitors and are considered immune-related adverse events. Side effects can result from a variety of different drugs, and the toxicities can really impact any organ system. And so we have to really use a wide differential in understanding the patients, their therapies, and the underlying context of their treatment. Next slide. Thanks. So we use the common toxicity criteria for adverse events that has been developed to create a common language, particularly for research purposes, and to compare across different studies. And the NCI has worked on developing and updating the CTCAE to help us understand toxicities, what to expect in our patients, and to help guide us in intervening. Toxicities range from mild toxicity or grade 1, where they may be asymptomatic or have very mild symptoms, all the way to grade 5, which is an adverse event related death, or grade 4, which are life-threatening and really require urgent intervention. Grade 2 and 3 toxicities are in between and may require some intervention, but patients may be able to continue with therapy depending on resolution of side effects and how we manage those side effects and their overall care. The next slide. So the types of immunosuppressive agents that we use to manage treatment-related or immune-related adverse events vary depending on the toxicity of treatment, the duration of the toxicity, and how the patients are responding. So to counter the iatrogenic effects of our overactivated immune system and that response, we turn to agents that will suppress or turn down the immunotherapy treatments. And we have to keep in mind that when we suppress the immune response, we may also be counteracting the efficacy of the immunotherapy that we're using to fight the cancer. And so we have to use really a holistic approach, caring for each individual patient in the most appropriate manner. For more severe immune-related adverse events, we often require bringing in colleagues and specialists that can help understand these toxicities and guide management. The first-line treatment for more severe toxicities will include corticosteroids such as prednisone and methylprednisolone, which can be given intravenously. For steroid refractory toxicities, we may then turn to additional agents or second-line immunosuppressives, such as infliximab, mycophenolate, tocilizumab, that sort of became famous in managing COVID patients, or other drugs such as tacrolimus or azathioprine. And we need to understand the use of these agents and bring in a multidisciplinary approach to use them most effectively. You're going to hear from my colleagues on further implementation of these options as toxicities become more severe in our patients. Next slide. Patient education is critical in preparing our patients for toxicities of therapy and what to expect on treatment. And because of the complexity of cancer care in general and immunotherapy in particular, it really requires a comprehensive and ongoing patient education program so that patients understand what to expect and can call us when they need help. Our patients not only turn to their physicians for help in managing these side effects, but also really value the support that's provided by advanced practitioners, nurses, and other support staff. So when we're going to turn to additional therapy like corticosteroids, we have to tell patients what to expect with those interventions as well, and make sure they understand what the potential side effects are going to be of those drugs. And we have to pay particular attention to patients who enter therapy with a pre-existing autoimmune disease, because they may have unique circumstances. And again, thinking about the multidisciplinary approach is critical for these patients. Next slide. So the general guidance in terms of getting ready to treat a patient should be that we're doing some baseline testing so that we're understanding where patients are coming from and what their unique risks and vulnerabilities may be. So baseline testing should include a complete blood count with differential, comprehensive metabolic profile, and thyroid studies, including TSH and free T4. Additional testing may be necessary for some patients, like a urinalysis or EKG, depending on pre-existing conditions. And these tests should be repeated intermittently or periodically as the patients go through therapy, perhaps every 3 to 6 weeks as they initiate therapy, And then if the patient is very stable, you may stretch that out to every 2 or 3 months. We also want to be familiar with the diagnostics that we're using to help manage toxicities and rule out other causes of adverse events that may occur to our patients that are going through therapy. And again, I think it's critical that we're using an entire team of specialists to help understand what's going on with these patients and how to manage them most appropriately, particularly for patients who have severe, refractory, or unexpected or unusual toxicities where we may need additional help. And we hope that the guidelines that we're providing and updating you on today will help you to use them on a repeated basis, and you can turn back to them again and again to understand and refresh your knowledge and understanding of the management of these patients. So thanks for allowing me to introduce these topics, and we'll now turn to Dr. Paulo Ascierto to discuss some commonly seen immune-related adverse events.
So thank you, Gregory, and I'd like also to thank Dr. Bramer, Dr. Ernsthoff, and Sitzi for this kind invitation. So you have seen the general concept about the immune-related adverse event. What I'd like to do with you in the next 10 minutes is to give a look to some immune-related adverse event, and especially the gastrointestinal and cutaneous, and how to manage this. The next, please. So if we look the top 5 adverse events from checkpoint inhibitors, as you can see here, there are the skin toxicity, the diarrhea and colitis, hepatitis, and then endocrinopathies and pneumonitis that is more for anti-PD-1. And the difference from the different checkpoint inhibitors, anti-CTLA-4 and anti-PD-1, is just the incidence. The highest incidence of this adverse event and grade 3 and 4 is for the combination. And then anti-CTLA-4, more incidence with higher dosage, and then the anti-PD-1. The next. So when we talk about the gastrointestinal adverse event, we talk about several conditions that are listed here. So the gastritis and the nausea and vomiting is part of gastritis, enteritis, diarrhea, the colitis that is mainly observed as abdominal pain, and the mucus or blood in the stool, and then still hepatitis, pancreatitis, and cholangitis. The next. So here there is an overview about the colitis and diarrhea that is the second immune-related adverse event more frequent in the treatment with checkpoint inhibitor. And it's immune-mediated, this side effect, and similar to the ulcerative colitis, as you can see also from these images, more frequent in combination with ipilimumab and nivolumab, and then with anti-CTLA-4, and then with anti-PD-1. Is one of the early adverse event, and the onset is in general between after the 4 weeks, and the time to resolution is the median time 2 weeks after the onset. But here you can see that the resolution can be also longer until 24 weeks. Next. Here you can see the workflow for the diagnosis of diarrhea and colitis. As I told you, the topical onset is between 5 and 10 weeks. And one of the concern at the beginning of the story with checkpoint inhibitor, with anti-CTLA-4, was the bowel perforation. And then with the algorithms that you have already seen from the Dr. Master presentation, this condition, fortunately, is really rare. As you can see here, for the diagnostic workup in the grade 1, we just do the CBC, the CMP, and the fecal lactoferrin. For the grade 2, the fecal calprotectin, and also the TSH and stool infection analysis in order to be sure that it's an immune-related adverse event. And for the more severe adverse event, sometimes it's required an endoscopic evaluation with biopsy or the CT scan. The next. When we look to the management of colitis, as it was already introduced by Dr. Master, in case of grade 1, we just have symptomatic treatment. For the grade 2, we need to withhold the checkpoint inhibitors and start corticosteroid at dosage of 1 milligrams per kilograms per day of prednisone or equivalent. And when we have a resolution side effect or grade 1 less than 10 milligrams a day prednisone, we can re-challenge the patients. For the grade 3, we need still to withhold the checkpoint inhibitors, but we need a higher dosage of corticosteroid, 1-2 milligrams per kilograms per day of prednisone or equivalent. And even in this case, we can consider a challenge when we have a grade 1 or less than 10 milligrams per day of prednisone. In case of severe grade 4, we need to withhold and potentially discontinue checkpoint inhibitor and start intravenous corticosteroid at higher dosage. And if the treatment with steroids don't solve the problem, we need the second step as shown by Dr. Masters. The next, please. About the nausea and vomiting, this is in general a condition that is not so frequent with checkpoint inhibitor, and is probably due to other condition. We don't need to use steroid in general for this. And it's more important the treatment of the symptoms. If we have no improvement within a week, it's probably useful to do esophagogastroduodenoscopy in order to evaluate what is happening in the trait of the gastrointestinal apparatus. Next. Hepatitis is another immunorelated adverse event after checkpoint inhibitors treatment, and it's more frequent in combination of ipilimumab and nivolumab. Then we have the same incidence more or less with anti-CTLA-4 and anti-PD-1, of course, with higher incidence with the higher dosage of anti-CTLA-4. Is immunorelated, and it's not an early adverse event. In general, we see the elevation of the transaminases after 1 month from the treatment, and the time to resolution may be longer, and the median is between 1 and 3 months after the onset of the symptoms. The next. So it's important to know the grading of hepatitis, and in general, we look to the transaminase, but it's also important to look to the bilirubin and ILKP. We have a grade 1 if the transaminases are between 1 and 3 upper limit of normal, grade 2 if between 3 and 5, between 3, 5 and 20, grade 4 more than 20. It's important also to know that transaminases can be elevated in case of liver metastasis. And it's also important to check the liver functional test prior to each checkpoint inhibitor infusion, since hepatitis may be otherwise asymptomatic, and in general diagnosis is done just on the value of the complete metabolic profile. The next. Here you can see the flow of the management of hepatitis. If grade 1, we just to take weekly the liver function. If a grade 2, that is to say, with the transaminases between 3 and 5 upper limit of normal, we need to look to the liver functional test and start prednisone to dosage of 0.51 milligrams per kilograms a day. We, of course, evaluate if we don't or not the checkpoint inhibitors. In case of grade 3, for sure, we should withhold the checkpoint inhibitors and test the liver function test every 1-2 days, and start higher dosage of steroids, a dosage of 1-2 milligrams per kilograms per day of methylprednisolone of equivalent. In case of more severe, we should discontinue checkpoint inhibitors, still start higher dosage of steroids, and look to liver functional test every 1-2 days. In case of a steroid refractory condition, we should start a second step with immunosuppressive agent like mycophenolate or tacrolimus. The next, please. Pancreatitis is a frequent immunorelated adverse event that in more than 90% of cases is asymptomatic And we can just see an increase of the lipase of amylase looking to the CMP profile. It's due to the T-cell mediated inflammation. And in general, we need just to withhold checkpoint inhibitor, start steroids in case of symptoms. The next, please. The most frequent adverse event, immune-related adverse event, is the skin toxicity. And skin toxicity may be in general the rash, the pruritus, and other condition. And it's an early adverse event, and sometimes the resolution may be longer. And in some conditions like the pruritus, this can also, the duration can be all the time of the treatment is immuno-related. And the time to onset, as I told you, is early. It's one of the earliest adverse events. The next, please. In the majority of cases, the grade is grade 1 and 2, but we can have also some serious skin toxicity like the Stevens-Johnson syndrome, and I will show you a couple of slides about this. It's always important to have a multidisciplinary approach with a dermatologist that can also suggest something about the workup and the treatment. About the workup, we should include the CBC, the CMP, and also the assessment of BSA involved by the rash, the assessment of special feature and patient's history of allergy or atopy. In case of severe adverse event, grade 3 and more, we should also consider a skin biopsy, and additional tests may be important for some severe toxicity, and checkpoint inhibitor should be had. The next, please. The vitiligo is not proper an adverse event. It's more a phenomenon that is in general is seen in patients in treatment with checkpoint inhibitors, and in general is related with a good outcome of the patients. The next. As I told you, the Stevens-Johnson syndrome sometimes is a syndrome that may be life-threatening, and for this reason should be treated as soon as possible because we have an involvement also not only of the skin but also of the buccal mucosa, conjunctiva, and genital areas, and this may be exposed to some infection. High dose steroid is recommended for this condition. The next. We can have also the psoriasis that is another autoimmune condition, and here you can see some manifestation. And it's really important to have the opinion of the dermatologist because the treatment of psoriasis sometimes is different from the classical approach with the steroids. The next. So about the management of this cutaneous adverse event, in case of pruritus, we can have the GABA agonist. Sometimes we can use topical oral steroids, but it's always important to, as I told you, to have the opinion, the consultation of a dermatologist that can also recommend some different treatment for other different condition. And if the rash doesn't respond to steroids, it's important also to check for infection, and for this reason, culture should be obtained. The next. So having said that, it's my pleasure now to introduce Dr. Igor Puzanov.
Thank you, Paolo, and thank you, Mark and Julie, for inviting me to this event. I will now continue with managing serious adverse events from the immunotherapy topic. Actually, all of the side effects, or almost all of them, can become serious. Remember the gradient slide. I think that's one of the most important slides here. If you are having suspicion that this is a toxicity from the immune checkpoint inhibitor in this case, you absolutely have to grade it according to the CTCAE 5.0 criteria. These are available online, and a lot of times you can actually download them on your cell phone. So you can actually look what grading that toxicity is. The one topic which is really serious is the cardiac side effects. Initially when we developed these drugs, initially, at the time, nivolumab, 2008 phase 1 trial, we didn't know anything about cardiac toxicities. It really came with a wider use, and first paper published in New England Journal of Medicine, next slide, where myocarditis was described in 2 patients on ipi/nivo clinical trial, and both of them actually developed that between days 14 and 16. So sooner than when they came for the second cycle. This is really important to know that the peak onset of myocarditis is about 32 days. However, the 95% confidence interval for the side effects is day 7 to 42. So it's the first 6 weeks, but it can come as early as a week after you gave the first dose. It's more prominent after the combination immunotherapy, ipi/nivo about 1%, but with a single agent PD-1, you can see about 0.4%. And most important, if you develop myocarditis, your patient, the mortality is somewhere between 40 and 50% based on the retrospective case series studies published by several groups. So this is a rare, but potentially, life-threatening side effects. The most common symptom is actually fatigue. The patient will basically feel like they're out of gas. There is like nothing they can do. They cannot get out of bed. Obviously, with time, they can develop shortness of breath, arrhythmias, which are usually coming a little bit later, but they can be also the sole presenting cardiac toxicity, atrial fibrillation, blocks, AV blocks, some chest pain, especially if people develop pericarditis. It's really important to have a high level of clinical suspicion. We have just published a paper, retrospective study of 1,000 patients at Roswell Park Comprehensive Cancer Center in Buffalo in JITC, Journal of Immunotherapy in Cancer. I will point to you that there we actually showed that weekly troponin measurements, at baseline and then weekly for 6 weeks, we propose we're actually able to catch these patients earlier with lower elevations of troponin as the most sensitive sign to detect. Of course, you get some false positives, and you have to sort through that. But the patients you detect early have better outcomes. It's a retrospective study. We need prospective studies. There is actually, next slide. There is actually going to be a prospective study using abatacept, a multi-center study led by our colleagues from Mass General versus the usual treatment. When you are suspicious for myocarditis, consult with cardiologist. Troponin levels are elevated in almost all patients with myocarditis. The EKG changes come a little bit later, especially blocks. If you develop first, second, and you can develop third-degree AV block, you obviously have to have interventional cardiology and ability to put in a pacemaker. Cardiac MRI is a golden standard, or endomyocardial biopsy. The problem is if you do not have that available readily and you have a high high suspicion, high clinical suspicion, you absolutely should start high-dose steroids. And what I'm talking about is a 1 gram a day of methylprednisolone for 3 to 5 days, then switch to 1 to 2 milligrams per kilogram prednisone. And the problem is if you then get the cardiac MRI on day 4 of high-dose corticosteroids and you get negative test, it's then going to be a little clinical conundrum. Are you going to believe the test, or did you actually treat the condition? And if you see the troponin go up and down and you don't have alternative explanation, I would propose that you simply consider it clinically detected myocarditis and finish the typical 4 to 6 week taper of steroids. Other useful agents, anti-thymocyte globulin, mycophenolate, abatacept, I mentioned, alemtuzumab, caution against infliximab, which can actually have some cardiac side effects. Next one. Pulmonary toxicities. On the left side, there is an excellent figure from excellent JCO paper by Jarushka Naidu and the group at Memorial Sloan Kettering, Jed Wolchak. one of the leaders there. And please look at the picture here. As you can see, especially the top figure, patient comes short of breath on immunotherapy, couple weeks in, they are hypoxic, you have clinical suspicion, this could be pneumonitis, you get a CT scan, that's the test to get, the X-ray very rarely will be definitive, and then you get these pictures. Some of them actually look more like a typical pneumonitis we are all familiar with, like the hypersensitivity picture or the ground glass, but the cryptogenic organizing actually may prompt you to think more about infection or maybe even a metastatic cancer spread. So just be wary and have this picture in your mind available. The interstitial is sometimes tricky because if the resolution of the CT scan is not as high, you may get fooled that there is actually nothing, while actually the interstitium is thickened, and it could be one of the presenting pictures of pneumonitis. Obviously, if you have consult with pulmonologist, sometimes with the broad differential, doing a bronchoscopy biopsy may actually be important, maybe fatal. So prompt recognition and management, again, unless you have contraindication, other etiology, I would say, sometimes start a steroids and 1 to 2 milligrams per kilogram, and if it's pneumonitis, typically it will respond, although refractory cases are known. Next slide. I spoke about that. Median onset is 2 to 5 months after starting the immune checkpoint inhibitors. However, remember, this is median, and we always have to think about outliers. So the confidence interval is actually 2 to 3 weeks to actually up to almost 2 years, I think 22 months. Julie will know more as a thoracic specialist, because they see more of pneumonitis in patients with lung cancer, history of smoking, and COPD. Next slide. Grade 1 is basically when you only see changes on the CT scan, but no changes in oxygenation or symptoms. You can continue your treatment. Grade 2, you stop the treatment and start a steroid. 3, of course, is when people are in a hospital requiring oxygen for, ICU. Grade 1, 2, we continue or, can reinitiate treatment. Grade 3, 4, 4 is probably pretty high for anybody's comfort. Grade 3, if you can hold the, discontinue the checkpoints, and let's say 6-8 months later, you have some progression and you don't have anything, I have actually restarted after counseling the patient, discussing and careful documentation, the checkpoints, or perhaps switch from one checkpoint to another. And, the retrospective data confirm my experience that about 60% it's going to be fine. And, about 40% you get either the same toxicity or different toxicity. But, definitely very, very careful, because this could be life-threatening. Next slide. Neurologic toxicities, I would say after cardiac toxicity, really the second most life-threatening. Guillain-Barré syndrome, very rare, but could be life-threatening. Myasthenia gravis, encephalitis, peripheral neuropathy can be debilitating, aseptic meningitis, and you see the incidence there over time. Neurologist is your best friend, and it is important to recognize and consult. At the same time, if there would be any delay, you have to manage immediately, because, delay of management, may actually be detrimental to the patient. Next slide. So myasthenia gravis, is not very common, but, has a high potential for fatality, obviously. Patient may again come with some fatigue, weakness, proximal muscle weakness, ptosis, facial weakness, swallowing problems, and may lead to the respiratory compromise, and may co-occur with myositis and or myocarditis. I actually remember a patient with myocarditis and myasthenia who actually recovered fully and is in complete response for now 3 years plus. Again, discontinue the offending agent. management together with neurology, ICU if needed, IVIG, perirostigmine, and obviously very, very high need for clinical suspicion. Next slide, the overlapping toxicities you can see here between myositis, myocarditis, myasthenia gravis. This is an area of research, and it would be good to know and who is predisposed for these severe toxicities. On the other hand, we monitor all patients carefully, and it's key to have a good communication systems for these patients so they can report their toxicities immediately. Next slide. Other life-threatening toxicities, Stephen Johnson mentioned by Paolo, type 1 diabetes mellitus, including DKA, and last but not least, the hemophagocytic lymphohistiocytosis. Next slide. So Stephen Johnson, Paolo described, nobody will miss it because it's very visible on the skin. People actually may end up in the ICU, and you will need to ask your burn surgeon colleagues because patient may end up needing, like a skin transplant. We have never seen it to that level, but there is a small but definite risk, and those cases were reported in literature. Next slide. Type 1 diabetes mellitus, less than 1-2% patients treated, typically later in treatment course, however, may occur as quick as after 1 or 2 doses. I have seen both. Patients really will present with type 1 diabetes. The islet cells are destroyed, and they are now in DKA, require ICU admission and treatment as such, and a lifelong insulin treatment. That is actually one of the discussions I have with my patients for example, adjuvant therapies, because again, we know the adjuvant therapies the checkpoints may help with disease-free survival, various diseases, but again, some of those patients may be actually cured, and you always have to weigh risk and benefits and know that some of the rare side effects, may happen, and if they happen in stage 4 patient, well, it's a tough decision, but if they happen in stage 3 and now perhaps even stage 2 patients with melanoma, as we heard recently about pembrolizumab top-line results, that is the discussion we all have to have, and personalized medicine we all have to practice. Next slide. Hemophagocytic lymphohistiocytosis. So it's a rare disease, life-threatening. It's due to macrophage activation. There are some inherited forms of this ailment, which have to do with NK cell and perforin mutations. They can happen after the treatments. They are rare. Maybe more common with anti-CTLA-4, but again, we have seen it with both. And what you typically see is elevated liver enzymes, cytopenias. If you check ferritin, it will be elevated. There is a fever, splenomegaly. There are some coagulopathies. And if you check, you will have elevated IL-2 receptor. And hematological consultation recommended, steroids, immunosuppressive, TOCI, etoposide, actually as a chemotherapy, may help, could be life-threatening. And that would be patient I would not re-challenge with the checkpoint inhibitors. So I think for conclusions, we have Dr. Bramer.
Yes, thank you very much. And thanks for our esteemed colleagues and part of our panel. And so I just wanted to conclude that, as we've seen here today, immunotherapy has become a standard tool in the management of cancer patients. And so understanding the unique side effects of immunotherapy is really critical for optimal management of our patients. And these toxicities can impact patients in any organ system, as well as at any point in their therapy, even though most of these toxicities can happen or tend to happen early on, but we can see these type of toxicities even occur when they're completed therapy. And as you can see today, multidisciplinary team management is important for managing these patients. But in general, these toxicities, while sometimes complex, can be managed easily when you have a team approach. So I think it's time to move to the questions. And you can submit your questions again by clicking the Q&A icon on the bottom of your Zoom control panel. And you can type your question and then click send. And then these questions will be answered as we go through them. And there's already great questions here. One, I think, to any of our panelists, but I'm going to sort of start off with Greg, Dr. Masters. There was a question from a rheumatologist who had a question about using C-reactive protein. Is this something that we should be recommending to follow in patients on checkpoint blockade? Should we look at it baseline and then follow it? And so they're wondering, is there a particular reason why this is not one of the recommended baseline labs?
And Julie, I think we did, that's a good question. We did discuss that in the group as we went over things. I think the issue with checking any lab in patients who are not symptomatic is that you're going to get false positives and then not be sure how to react to that. We are stimulating the immune system with the immunotherapy drugs we're using with the checkpoint inhibitors. And so, unless there's a particular toxicity that we're trying to evaluate and manage, I tend to not do extra testing because treating the cancer to me is the most important thing. Now, there's some difference if we're treating in the adjuvant setting, especially maybe for lower risk patients, but particularly for advanced stage patients where this is their best option for controlling the cancer. That's not something I've been routinely checking because I'm not sure what to do with the results.
Yeah, I'd be not sure, like, is it their cancer making it worse versus the immune treatment? But I do agree that it would be something to look at in the adjuvant setting. I mean, Paulo or Igor, any thoughts about CRP following that?
No, so I can just add that we know that CRP may be important as a prognostic marker after the results that Jeff Weber presented with CRP and IL-6.
Okay, thank you. All right, Dr. Acierto, question for you. Assuming a patient is receiving both anti-PD-1 and anti-CTLA-4, how do you determine what to discontinue or whether or not you can restart one of the drugs? Do you restart both or do you drop one or the other? How do you decide?
So it depends. As first, if we have to stop the treatment, we should stop both the treatment.
Okay.
And of course, it depends by the grade of the toxicity, because if you have a grade 2 that is solved very soon by steroids, we can then treat the patients still with the combination. If you have a more severe adverse event, the patient was already treated with 3 cycles, probably we can stop. It's also important to know that if we have a toxicity and the patient is a severe toxicity, grade 3 and 4, the patient is responding, we don't need to continue. We can stop the treatment, follow the patients, because sometimes, and this is mainly with the combination, patients continue to respond.
All right, there's another question, Dr. Pusanov. One of our listeners noted a recently published paper in CCR that showed early use of corticosteroids for the management of IRAEs was associated with poorer survival in patients with advanced melanoma treated with anti-PD-1 monotherapy. Now, in the longest, we figure that steroids are typically safe and shouldn't affect the outcomes, and some studies actually showed no effect. But your thoughts about this new paper? I guess I was not aware of that. So
yeah, I do. This is an experienced group from MGH and I think other 4 centers. It's a retrospective study, like most of the studies we have done so far. Remember, the data Dr. Bramer actually noted were obtained from a databases of thousands of patients treated with checkpoints as well as steroids. This paper actually gives a little more granularity into the question they actually were looking at hundreds of patients retrospectively who were treated with checkpoint, and they were asking a question how soon they had to be treated with a high dose glucocorticoids defined as more than 60 milligrams of prednisone per day. And they actually concluded both from the MGH cohort as well as the kind of validation cohort from all the other hospitals, that if you had to use high dose steroids sooner than 2 months into the treatment, you actually develop poor progression-free survival and overall survival afterwards. And if you think about it, it actually does make sense, because what it means is that you only got 1-2 doses of the checkpoint, single agent checkpoint, to mind you. This was a single agent PD-1. It was not Ipi/Nivo, where there may be some important differences. And if within 8 weeks you had to stop and give high dose steroids, you may just simply activated the cells and then you killed them. And there may not have been enough time to develop appropriate memory cells, cells which would survive this kind of the killing spree. And then afterwards, remember what we talked about, that these patients were at least by definition grade 2, some of them grade 3, and remember the guidelines, grade 3, be cautious, try to give them some break. Grade 2, you may resume. So I think that's the main reason for this result. And basically it just says caution, if you are early in a treatment course and can avoid using high dose steroid, try that, but at the same time, if the event is so severe, let's say cardiotoxicity, myocarditis, you don't have that leisure. You give 1 dose, you develop myocarditis, you will be given 1 gram of solumedrol. And this article says that if that happens to you as a patient, it will affect your progression as well, overall survival.
All right. Well, thank you. That's great. How about, does any one of you have experience using omalizumab, the anti-IL-5 for persistent or refractory pruritus? I have not used it, but
No.
yeah. Okay. I have not. We'll check into that, get back to you. And then one other question was, why check fecal lactoferrin for grade 1 toxicities, but fecal calprotectin for grade 2 colitis?
This is an interesting question, because both the marker are biomarker for the bowel the inflammatory disease. So, in general, if you have a grade 1, this is just a suggestion, because the treatment of grade 1 is just to treat symptoms. And if you have to do a marker, because you had probably the lactoferrin, it's easier to do. But are both good markers. It's just that the lactoferrin, it's easier to do.
Yeah.
Okay. And then one other question was, in case patients have SJS for nivolumab plus Ipi, can we resume the drug once the event resolves? And if yes, would you resume one or both? I don't know about you, but I'm not sure I do anything.
No, yeah, I don't feel to resume the treatment. Of course, this depends. And as I told before, so if a patient is a patient that is on response, we can follow the patients, because if he's a response, this can continue to respond. In case of progression, in case of patients with melanoma BRAF wild type, so I don't feel to start again the combination. Probably we can consider the single agent anti-PD-1. But we should keep in mind that the Stevens-Johnson syndrome is a life-threatening event.
Yeah,
exactly.
I agree. And, I will point to the study done by Memorial Group, Mike Pasto, looking at 2 doses of Ipi/Nivo. And it's a small study, but one interesting feature is that actually 2 doses of Ipi/Nivo looked like they were not less toxic than 4, because in real life, actually, the median number of doses is somewhere between 2 and 3. So
Okay.
yeah, if you got 2 doses in, you got in everything you needed. 3.
Okay.
Yeah,
There's,
and I would be cautious restarting the CTLA-4 inhibitor. That would worry me.
I agree. There's a couple questions that are very similar to each other. Are besides the myasthenia and myositis and the myocarditis, are there other multiple IRAEs that tend to cluster together? And then also kind of if someone has a low grade IRAE, does that predict the potential for developing another? Any thoughts?
Yeah.
So, sorry. Go ahead.
Well, no,
No,
all
go
right.
ahead.
Either one. No, I just want to say the second, yes, if you have a low grade something, it's brewing, it's probably it's gonna come. And in terms of like clustering, I cannot really tell.
Yeah, so if you have this kind of side effect and there are patients on treatment with the combination of anti-CTLA-4 and PD-1, there is a higher risk to have 2-3 different side effects, more than with a single agent.
And are there any patients that you think that you can kind of pick out that are going to be in the population that will develop severe toxicities? Have you, in your practice or in your research, noticed anything?
Well, I think definitely patients with pre-existing autoimmune disease, and I think particularly of patients with Crohn's and ulcerative colitis, that, if you have the discussion and start therapy, I'm extremely cautious in those patients because they tend to be tough patients to treat.
All right. And then is there, in your decision process, is there any decision to switch from one ICI to another ICI?
But the question is from the 2 different PD-1 or from an anti-CTLA-4 and anti-PD-1?
I don't know. What do you think? Your
So
thoughts,
probably
particularly in melanoma? So
in melanoma, now the combination of anti-CTLA-4 and anti-PD-1 is considered the standard of care. And in general, if you in country like Italy, we don't have the reimbursement for Ipi/Nivo. We use anti-PD-1 as first and second line anti-CTLA-4. Having said that, probably the question is about a different anti-PD-1, if we can switch from one and another one. So in Italy, it's not possible, and I don't have experience. I don't know if in US you got some experience.
Yeah, I have done it, and with some success. Switching from Pembro to Nivo, let's say for you mentioned some of the skin toxicities, rash, bullous pemphigoid switched, and actually the other one didn't do it. Remember, in efficacy, the PD-1s actually seriously do not work one after another. That's Georgina Long and her publication on a 0% response, Pembro after Nivo or Nivo after Pembro in melanoma patients. But in terms of toxicity, these molecules are different. We all know it's not just the molecule, it's actually how they are dissolved, what other chemicals, go into the drug, making. I think it's a possibility, to switch, if you have toxicity, and switching from CTLA-4 to PD-1. We actually don't really do much of that, because if we use CTLA-4 these days, we usually use it with PD-1. So it's more the answer to the question, which one you continue, and Paolo, you answered that well, you continue the PD-1. So that's what I would say. There are rare cases where you may just use single agent Ipi if you worry about a patient. I remember a case we shared with Mark Ernsthoff, and a transplant recipient, and trying to use CTLA-4 instead of PD-1, although there is so little data that it's controversial if it even makes a dent of a difference using CTLA-4 or PD-1, because obviously you are boosting the immune system in the setting of transplant organ recipient. and cancer patient, which is like a triple whammy situation.
Well, thank you. Yes.
Yeah, I would just add, particularly for infusion reactions, as Igor mentioned, that these molecules are prepared differently, and you can get away with limiting infusion reactions by switching from one to another.
Excellent points. Well, we're at the top of the hour, and so we want to thank all the attendees today, as well as our esteemed panel. And thank you very much to my co-chair, Dr. Ernstoff. Don't forget to claim your CMEs, and we'll have information up to help you through that. Miles, I'm going to pass it off to you.
Thank you, Dr. Bramer. And yes, thank you all panelists for sharing your expertise in IRAEs today. It was a very interesting discussion, great questions from the audience. I'd now like to make you aware of a few other SITC events and opportunities. If you enjoyed this webinar and would like to dive deeper into ICI toxicities and management, join us on Thursday, September 16th from 11:30 to 12:30 Eastern for the webinar Practical Management Pearls for Immune Checkpoint Inhibitor-Related Adverse Events. And coming up on August 25th from 5:30 to 6:30 Eastern, we kick off our urothelial cancer immunotherapy series with an accredited guideline overview webinar. You can learn more and register for these free events on the SITC website. Our deep dive seminar series on targets for cancer immunotherapy has 2 upcoming sessions focusing on adenosine and macrophage biology for anti-tumor immunity. You can see the full list of series topics and register on the SITC website. Our Advances in Cancer Immunotherapy series has an accredited online program coming up on September 15th that will focus on gastrointestinal cancers. Visit sitcancer.org/ACI for more information. CME credit is available for reviewers of the Journal for Immunotherapy of Cancer. You can find more information at sitcancer.org/JITC. And finally, as Dr. Bramer mentioned, continuing education credits are available for physicians, nurses, and pharmacists who attended today's webinar. You'll receive a link within a few days with information on how to claim credit. A recording of this webinar and the presentation slides will be made available on the SITC website. All attendees will receive information on how to access these by the end of the day. If you have any questions or comments about this webinar, please email connected@sitcancer.org. Thank you, everyone. That concludes the webinar.